Well, so with that, we are now going to reconvene for the next panel, which is our state panel. We're going to first start with Erica Murray, President and CEO of the California Public Hospital Association, as well as Dr. Neil Kahatsu, who is the Medical Director at DHCS. I am going to first turn this over to Erica.
Thank you, Lisa. I really want to thank Peter, everybody at Harbridge Consulting and California Healthcare Foundation, Blue Shield of California Foundation for putting today's event on. It's been terrific so far, so thank you very much. And I want to make a special shout out to Dr. Neil Kahatsu. The partnership that we have had with the Department of Healthcare Services, and specifically with Neil and his team, I just can't thank him enough for your extraordinary leadership. We are so fortunate in California to have Neil at the helm of the DSRIP, and I just want to thank you very much for the partnership. What Neil and I decided to do for this part of today's conversation is to do a little bit of tag team. We want to share some thoughts and reflections, some real lessons learned as we are now in the final year of the DSRIP, and some lessons learned with all of you. So I'm going to do that sort of retrospective look and a little bit of navel gazing, and then Neil's going to take that and articulate the state's vision for DSRIP 2.0 in California. So I know you got a high level of this before, but I think it really is. You can't really overemphasize it that California was the first, and that this was a huge opportunity to think about pay for performance in the safety net in a new way. But there was no precedent, and so some of what I'm going to describe is sort of the story of how we got here and how even the DSRIP came to be, because I think that might help ground our thinking about where California might take a DSRIP going forward. So as David Lown and others noted this morning, the DSRIP came about as a result of the Obama administration, and I want to specifically mention Dr. Don Berwick, who was then head of CMS, and many of you know his visionary leadership around system transformation. There was a real recognition that the underfunding of California's 21 public healthcare systems was going to significantly hinder California's ability to successfully implement the ACA back in 2009. And California had already distinguished itself starting years and years before this, but notably in 2007 with the development of the County-Based Coverage Initiative program, and the conversations in 2010 around a 2010 to 2015 waiver were also centering around how to take those coverage initiative programs and build them up into what we all know now as the low-income health program, the precursor to Medi-Cal expansion in California. There was a real recognition that coverage expansion alone does not guarantee access. And if all you do is simply tell someone they're now in a program or even give them a card, that's not going to guarantee that they can get the kind of care that they need. And one of the ideas around the DSRIP was there was an opportunity to marry that coverage expansion with delivery system transformation to really change the system and make care more accessible, available, and higher quality and patient-centered for those who were going to be brought into the system. But as I said, there was no precedent for this kind of pay-for-performance program in the country. We had the Medicaid EHR program, which created the structure of achieving certain milestones and then receiving reimbursement for those, or receiving federal payment for those incentives. And at the time, CMS was also working on developing their Medicare ACO regulations. But those were the two programs that were existing at the time that touched on this idea of what was then a DSIP, by the way. CMS added the R in 2011. But we didn't know exactly what CMS wanted, and CMS itself wasn't exactly clear what it wanted. I think just as we were thinking in California how to marry performance and finance and quality improvement in the safety net, CMS was figuring that out too. I mean, they didn't know who the appropriate experts were within their own team, what exactly they wanted to emphasize, and how all of it should fit together, whether there should be four distinct categories or four interrelated categories. So it was all very much lots of back and forth. We, with CAPH and I think the state, we were all very fortunate to have the California Healthcare Safety Net Institute, the mouthful that Dr. Lown referenced this morning. They are, as he referenced, the quality improvement affiliate of CAPH. They had 10 years of experience working directly with the public healthcare systems in California on very specific quality improvement programs across the state, many of which had direct support from the California Healthcare Foundation or the Blue Shield of California Foundation and others. Things like chronic disease management and patient visit redesign, other system-based efforts, learning collaboratives as they are called, that helped us understand sort of what works, what doesn't work, what metrics may be appropriate. Each of those learning collaboratives themselves used nationally vetted metrics to track performance. So there was a real, there was already some expertise within California of these types of projects that would seek to make care more integrated. The trick with the DSRIP, with this size of a program, was how to sort of take those pockets of excellence and put them on steroids. But as it's been noted, I just think it's important to emphasize, because CMS didn't know what it wanted, we stumbled a bit, as would be expected. I know Peter referenced this morning the story of Texas's reporting, and that stems from, in California, when we submitted one of our first mid-year reports, when all of the systems submitted their reports, there had been no actual clarity about exactly what level of detail would be required in these reports. So naturally, as we are used to representing 21 different systems, some submitted real detailed reports and others just sort of answered the questions. And CMS was clearly unhappy about the range of detail. And I think that is the reason you see the Texas DSRIP. And those reporting, we once saw a checklist for the state of Texas for its report, and I think you can't even print it on a single page, all the different things that they have to check. I'd say another example of in reflection, well, I am not going back with my slides, am I? Okay, here we go. Another example of this ambiguity had to do with what was called Category 4, which they called urgent improvements in care. Dr. Berwick said, we know the problems, we know what you need to do, you just need to do it. And that seemed very simple and straightforward. It turned out to be the least simple and the least straightforward of all of the work. All the categories 1, 2, and 3 were heavily outpatient oriented and population medicine oriented, and category 4 was the inpatient patient safety category. And it turned out that we know what the problem is, but actually defining how you tackle something like sepsis and measuring that and making sure that you're measuring apples to apples is much more complicated, especially at the time when there was no national set definition or standard. So instead of just diving into the work, we had to spend a fair amount of time working with the department to even understand what it is we were talking about and how each system defined it and measured it so that we could move forward. I'll also say an example of CMS not really being clear what it wanted, and I would posit that this is still true today, has to do with milestone achievement. California has been wildly successful in its DSRIP, and on average, we have about a 98% achievement rate, which is fantastic. Except that sometimes when we speak to CMS, they say, oh, well, that means your milestones weren't ambitious enough. And I just think that's like being told, oh, you got straight A's from Cal, you should go to Harvard. I mean, it's unclear, well, what percentage achievement would show you that these were indeed ambitious? Is it 80%? Is it 90%? That's one of those issues that it's in the eye of the beholder, and I think it would be helpful for those systems and now those regions to understand, do you want us to shoot for 100% achievement in these or is it 80 or 90%? What shows you that there really is significant work going on? I'd also mention that when we started this program, there was lots of conversation about innovation and the importance, a real recognition of what it means to change a system. And the Plan, Do, Study Act, the PDSA cycle of making small tweaks and trying it out and seeing what works, and if that doesn't work, try something else. If that doesn't work, all that minor innovation that leads to major innovation, which leads to system innovation. Except that there's a rub, because innovation, and even that description, is predicated on some failure. Well, how do you build in failure to a pay-for-performance program, with these, especially with these underfunded systems that are so reliant on achieving that milestone? It's a real tension. But there's been really, really good work that's happened and an incredibly meaningful system transformation as a result of the DSRIP. And I won't be my typical cheerleader self. We could spend all afternoon doing that. But I will just say that there are some significant examples. One of the most obvious, and Dr. Katz is here and he can speak to this, in Los Angeles, over 350,000 people were impaneled into medical homes. And again, if you remember how Healthy Way LA was expanding coverage to people who would then ultimately become eligible for Medi-Cal, that is huge. And to make sure that those patients are not just getting coverage, but they're getting care in an assigned medical home, and that that clinic, whether that's a county clinic or a PPP in Los Angeles, is taking responsibility for that panel of patients, that's a huge systemic paradigm shift for Los Angeles. Also in San Francisco General, I think it's a really good example. They founded their DSRIP strategy on the recognition that their entire staff needed to be trained in system transformation, and they created an in-house learning academy, which has become a best practice for all the other public healthcare systems that have come to San Francisco General to see how this learning academy trains all of its staff in everything from lean to other efforts. And I'll also note that San Mateo Medical Center also used lean, and as an example, there was a question about this, using lean, working with their in-home supportive services, they reduced the time from the first contact from the first contact to the home visit from 75 days to 30 days, which I think is a really good example of good achievement. I'll skip over category 3 because I'm getting the hook. But I'll say that the variation in these systems, we were so aware of how varied each system was. Each one started at a different point. And in hindsight, that has led to varied plans. And it makes it harder to compare apples to apples. And I know Neil will talk about the reflection that we need to be more standardized. If you look at each plan is powerful, but it's hard to tell an aggregate story about our DSRIPs because they are so highly individualized. And so looking ahead, the main conclusion that I think we both share is that system transformation takes time. It just does. Each of those little PDSAs and leading to that system transformation, it takes a long time. And we have made huge strides. There is much more work to do. What we asked our member systems to do is setting aside everything, the entire waiver, where DSRIP is just a component of that, understanding that the state has articulated a comprehensive set of proposals, including things like housing and other efforts to reform safety net financing. But we said, set everything aside. Where do you need to be in 2020? And this is what the public healthcare system said. They need to be models of integrated care that are high value, high quality, patient-centered, efficient and equitable, with great patient experience and a demonstrated ability to improve health care and the health status of populations. So I'll leave it to Neil to tell you about what we're going to do with that.
Erica, thanks so much, and I want to thank you for your very kind words, and it's been a great partnership working with you, Dr. Lown, and the whole team as we've learned together and worked with CMS in DSRIP 1.0. We've learned a lot, and I want to emphasize that those learnings that Erica has just reflected on, some others that I may touch upon, are definitely included in our thinking about at least in concept, DSRIP 2.0, as well as from the morning panel, what we've learned from other states and CMS's evolving kind of approach to healthcare transformation. So I might just go back in just to highlight the context, the importance of context. We are tied and look very closely at the national quality strategy. The department's quality strategy is in turn modeled very closely after that. So ties to what we call in the department the 3-link goals, otherwise known as the triple aim. Ours is a little bit slightly different, and the priorities, which I won't go into, are key and I think foundational. And some of the themes that came up about thinking about a population-based approach, I'll highlight momentarily. Besides the tie to the national quality strategy, we have to appreciate that there was a large planning process by executive order, the Let's Get Healthy California process, which actually was the foundation for, unfortunately, we did not get the State Innovation Models grant, but the foundation for that was the Let's Get Healthy California plan. And just quickly, it's been alluded to, we need to think about the overall context of the waiver. I won't go into great detail, but there were 4 major goals that were laid out when Mary Cantwell presented a webinar on the initial concept of the overall waiver. Strengthen the primary care delivery system, 1. 2, avoid unnecessary institutionalization and services by building a foundation for integrated delivery system with proper incentives to push quality and efficiency. 3, address social determinants of health. And 4, use the Medi-Cal program, as Eric alluded to, as really a center for innovation to bring about whole person care. So I'll come back to some of those themes. I'm hoping I make that clear how we come back to those. So I'm going to move quickly through this so we can get to the reactor panel, because I'm very interested in their comments. In terms of these domains, some of the themes I just mentioned I think are reflected here. We have to be able to get a DSRIP 2.0, we have to convince CMS that, in fact, we are transforming the delivery system in a major way, that we're doing a better job of coordinating care, particularly for the so-called super utilizers, that we target better resource utilization efficiency. Institute of Medicine, as was commented on this morning, estimates that there's 30% wastage in the system, and that number has been thrown around for at least 10 years or more. And prevention and patient safety, really part, again, of the national quality strategy and the DHCS quality strategy. I'm going to move rapidly through the domains. I won't go into every project area, but there are specific projects in mind with in many cases, National Quality Forum metrics. CMS was very demanding that the metrics be nationally tested, be valid, and that's part of our learning from DSRIP 1.0. So in the area of system transformation, advancing patient-centered medical home, you heard about that in New York, aligning with national standards of what that means, better specialty care access, projects targeting transition from acute care, so that means from inpatient, from the emergency department, into whatever setting, whether it's home or some other transitional facility. And you heard about it a lot this morning, and we think this is critically important, integration of physical and behavioral health, and I would add in the social dimensions of health. The second area I mentioned, the second domain, and was or is approaching superutilizers in ways that make sense, that really benefit the members, patients, and families. So better complex care management for the so-called superutilizers. Health homes, one target population in particular, foster children, because there's often a multiplicity of needs in both medical, behavioral, and social, as one example. Care transitions for those who are leaving incarceration and moving into society. Just one of the target areas to think about. It's been estimated by some that the percentage of men in prison that have hepatitis C is somewhere in the neighborhood of 30%. The treatment for hepatitis C can cost upwards of $200,000 per person, although there's a high cure rate. That's just one example of trying to think about who is coming into the Medi-Cal program, single adults, and particularly those who came from an incarceration. Improving chronic pain management. That is a big part of emergency department utilization. It's a big part of opiate misuse. And so getting a better handle on chronic pain management will help us deal with the opiate abuse epidemic, which is a huge burden in terms of both mortality and morbidity and many other costs to society. And advanced illness planning, all of this in the area of taking care of high-risk, high-utilizing populations. Resource stewardship, again, I'm giving you just examples of areas that, of projects, programs that would fall under these domains. Improving antibiotic stewardship, it's well known, the literature is quite convincing that inappropriate antibiotic use leads to mortality, morbidity, and excess cost. Likewise, in imaging, high-cost imaging can be harmful in terms of radiation. It can be harmful in terms of costs, leading to unnecessary testing. And so it's one of the areas that has been called out for a long time of better management under resource stewardship. Similarly, high-cost pharmaceuticals and blood products. If you look at the national data, there's quite a consensus overall. I'm not talking about individual hospital data, but overall nationally, many inpatients receive blood products inappropriately, and it has substantial risk, which is often unappreciated or underappreciated. In prevention, the Million Hearts Initiative, which is part of the National Quality Strategy, the ABCS, with our more of an emphasis on blood pressure control and smoking cessation, also aspirin. Improving breast, cervical, and colorectal cancer screening modalities that have a clear benefit but tend to be underutilized, especially in certain subpopulations, so addressing disparities. And there's a lot of room for improvement in perinatal care, whether we're talking about C-section rates, prenatal, and postnatal care. Patient safety, just a couple of examples. There's a CMS global measure looking at healthcare acquired conditions across the board. This is just an example of thinking how you really have to change an entire culture. We talked about that importance. Another example is trying to reduce or eliminate the use of inappropriate surgical procedures, another area. Again, these are examples. I want to close and then turn it over to the panel before we move to questions. I just wanted to emphasize that, as was mentioned this morning, CMS says we aren't necessarily sure we want to do a DSRIP 2.0, not just California, but anywhere. They will need to be convinced. And so I think one of the questions that I think the panel will address is, I've given some of the drill down detail, but if we were to list three things, what would be game changers? What would be overall population health goals? And back at CMS, I can assure you that population health is very much on their mind. So how are we changing the system in a very broad fashion? I just throw out, this is just really musings, and I'll close. With the programs that I outlined, as I said, as an overview, wouldn't we see a reduction in hospital days, particularly related to the prevention quality indicators? Wouldn't we see an improvement in pain management and better, therefore, less opiate abuse? And thirdly, won't we see better access, both in terms of primary care and prompt access to specialists? So I think those are things that are measurable, that are population health, and which our projects would help drive, and I think would be a good reason to do a DSRIP 2.0. So let me leave it there.
Great. Thank you, Neil, and thank you, Erica. That was actually a perfect segue into our reactor panel. On our reactor panel today, we have Dr. Mitch Katz, Director of LA County Department of Health Services, Bill Barcelona with CAPG. We also have Cindy Enos, EVP of Healthcare Talent with Copel Solutions, as she's subbing in for Alan Miller today. and as well as Terry Leach, who is an independent policy consultant and formerly with the UCs, working with UC hospitals on DSRIP. So I'm going to start with Dr. Katz. Your reactions to the presentation, as well as what are the 3 game changers that you can see that would be important to put on the table?
Great. Well, thank you. And I think game changers should be how we think about it, as certainly in our previous DSRIP, maybe to tie a few of the themes together, I'll tell you that at one point I needed to divert a large number of nurses and pharmacists in order to add true but presently missing documentation in order to be able to get the money. Right. And so, why did we achieve so well? Because the huge amounts of money were on the table. And so, of course, any system will divert whatever resources are necessary in order to be able to get the money to do all of the things that we want to do. The real problem with that is that some of the things in DSRIP, in the previous DSRIP, are not that important to patients, to their survival. Some of the things have shown, for example, probably the use of anticoagulation for patients who are hospitalized to prevent embolism, thrombus, clots, probably is not as effective as people thought it was. It's certainly not in any way transformational of the system. And I hope that part of what we are able to do in this next round is transformational. And so then if you turn around and say, what would transform a system from the point of view of a patient, right? Because that's what we should be here for. We're healthcare providers, right? We shouldn't be all about the systems. We should be all about the patient and figure out what it is that the system needs to do to provide the patient what they want. So, what are goals like that? I mean, I would love to see as a DSRIP goal that everybody who entered a hospital or left a hospital had an identified primary care doctor. I think that would be transformational. Large numbers of people come to our hospital without a primary care doctor. And if you said, and it is true, I'm very proud, we're actually up to 450,000 people impaneled. But there's no DSRIP requirement. There's certain documentation that I have to make about whether or not the person did or did not get prophylaxis for a clot, but no problem with my just sending the person out without a primary care doctor, right? That's right. But what do our patients care about? They care about a longitudinal relationship with someone who cares about them. And I would also say that about all of the various homes and level 1 and level 2 and level 3, all of which I believe in. People care about is whether or not there's somebody who cares about them. Whatever form that takes. And for different people, it takes different forms. But at the end of the day, that's transformational, especially for very low-income people living in very stressful conditions, out housing that's really of a good standard, certainly often without food, without transportation. What is transformational is somebody cares about them. Someone is focused on their needs and working toward their needs. I think we should set ambitious goals about decreasing hospitalization. I think there remains much unnecessary hospitalization. I think we should set ambitious goals about eliminating tests which still go on in all of our systems that have been shown to not be helpful. If I were choosing one, I would set an ambitious goal that we're going to decrease by 30% how much ionizing radiation people receive. Well, but I guess what I'm trying to illustrate is I would do broad goals, not that we're going to decrease the number of just CT scans. But I would say broadly, we want our population, ionized radiation is becoming a leading cause of cancer, which is quite ironic since we're usually doing these tests to detect cancer. And instead what we're mostly doing is causing cancer on a population basis. So those types of goals that really get to people, I would certainly have one around the social determinants of health and trying to articulate what would represent on a population basis a higher function. I would look at things like we were going to decrease on a population basis the number of homeless people. I would look on a basis the number of people who are hungry. I mean, I know that these are things that will strike certainly hospitals as, well, this is way beyond anything we can do. And I understand that criticism, but the truth is, and it was said before, I think it was Nirav who talked about it, that hospitals are often centers of communities, and these are reasonable goals for us to do on a population basis.
Thank you. And Cindy, what do you think? I mean, especially given the work that COPE has done in other states, DSRIP as well, what would you say are the 3 transformational things that we could do in California?
COPE Health Solutions is currently working on actual implementations now in Texas. We're in year 3 of participation in the DSRIP projects in Texas with great success, a lot of good success focused on developing regional plans or regional policies around this DSRIP transformation. Also working in New York on a much more nascent basis and working with Harbridge Consulting on a number of those projects. So we actually do have a great deal of experience on the ground on implementation of how do you actually do a regional kind of approach. So my remarks will be both a combination of what I've seen in terms of some of that work, but also perhaps bringing in some of my former role directing the Department of Managed Healthcare. Because to some extent what I see in this transformation is that hospitals must make sure that as they're doing DSRIP work, that they're not just chasing dollars, that in fact this represents a real approach to developing sustainable capacities and payment mechanisms for hospitals to move out of a heads in beds model and into a model that in fact allows them to be sustainably reimbursed and compensated for moving care into the community. That is a fundamental conundrum, and I see a lot of moving around that, but I don't see how that actually really gets addressed. And so the second thing is that the hospitals, again, must work on strategy. That must be not just, hey, we're going to work on a DSRIP project. Rather, it must be, what is our strategy? And I thought it was great that Erica was able to really state the vision of the public hospitals in terms of where they're going to be in the universe. And I would suggest that a lot of hospitals really don't have a very good sense of that because it's very, very hard. So I think that's really important. The second thing that I think is real important focus is bringing in this health plan role. I alluded to that, and one of the concerns I have is just I'm not seeing the health plan engagement in all of this. So you have health plans in this current environment and contractual relationship with Medicaid and with payers. The health plans stand to benefit the most right now from the work that is done in the delivery system to reduce costs, move care outside of the hospitals into lower cost settings. And so, I'm really concerned that the health plans aren't receiving sufficient engagement around what is their to-do list. And to me, their to-do list maybe comes back to some work Neil Kahatsu and I worked on Right Care Initiative in trying to develop common approaches to common metrics around quality reporting, common authorization, referral process, all of the things that providers, when you come to them and you say, wow, how could you reduce your inefficiencies? They generally will say to you, well, if I could get a common DOFR, a division of financial responsibility from all the health plans, if I could have some common payment arrangements rather than I've got capitation here, I'm getting paid fee for service over there. This quality reporting issue, having 27 different kinds of reports due from health plans. All of these things layer a great deal of cost on hospitals and on providers that I think there is in this era of accountability, there is an accountability that must be assumed on the part of health plans to pay reasonable monies. That means that they don't get more than 10 to 15%, and that 10 to 15% is strictly accounted for in terms of what is the value they're adding. And then secondly, that they are in fact adequately reimbursing providers and developing those common metrics. The third thing is just that this notion of doing things from one plan to another. The hospitals that are really involved in safety net care, again, have a lot of this churning effect. And reduction of that churning by developing payer systems that attach to the patient and in fact allow them to stay with the same provider system is absolutely essential. So I would again suggest that the focus of the next waiver also incorporate a larger role perhaps for bringing in the health plans into system transformation.
Great, thank you, Cindy. There's some really interesting points there, and I do want to get back to your point about the role of not only plans but also other stakeholders. That will be the next question for the panelists. But Bill, 3 points.
Okay. Listening to the earlier panel talk about the goals in some of the previous waivers, Texas, Massachusetts, and New York, what I pick up on immediately is CMS's overarching desire to limit their financial exposure, to decrease the cost structure of these publicly funded programs through the waivers. And that's a daunting task when you shift from fee-for-service to capitation. And in those states where you have much higher cost structures to begin with, you have much more room to maneuver, although that's a gross oversimplification of what their experience is going to be. But here in California, we have such a lean payment stream. I mean, we've been doing managed care for 35 years. We've been capitated with half the population for 30 years. And my folks in the physician groups that are capitated and delegated have had vast experience with this. And I'm concerned that in this coming waiver, California may not be able to whiteboard enough cost savings to attract CMS. So I think we have to do a lot of hard work around who's going to partner with whom, who's going to bring experience to the table that's useful in terms of population health management, in terms of long-standing experience with the target population, handling the financial risk involved in moving to capitated payment systems. And we've had so many silos regarding this. I mean, my folks have been in silo A, dealing with commercial and senior populations, doing a lot of these things, doing population health, managing financial risk, creating cultures, organizational cultures that incent alignment toward meeting population health goals, but also delivering lower, value, increased value at lower cost. But they don't necessarily have the experience with these target populations. And at the end of the day, the way you succeed in a capitated payment model is knowing your patients. There's no other way to do it. You have to know your patients intimately. You have to understand the social determinants of health. And that's where the safety net silo brings the experience. So I think when I look at this, that it's got to be the proposal needs to be a marriage of the two silos and a bridging. I think when you move to greater risk, which we certainly are, you've got to spread that risk among parties who have experience with the patients and parties who have experience with the risk-based system.
Great. Terry, please.
Well, this comes from my previous role as the head of innovation for one of the largest health systems in the country, now a current position I have in which, in one of my roles, I'm consulting to a county that is attempting to get a jump and become a regional player and bringing many, many competitors and organizations, not-for-profit organizations together. And I think, and I also want to refer to one of the previous speakers, Nareb from New York, I think we have to start with a vision. Before we talk about 3 tactics, we have to talk about the vision that California will have to go forward to be able to have this conversation with an already skeptical CMS, where California is concerned. And if our vision is, for example, timely, affordable access to high quality and culturally competent healthcare and health, and also mindful of CMS's objective that we lower the spend, we also have to think and integrate into this vision stretch goals that will show that we're serious. And by that I mean in recognition of the silos that Bill just alluded to, where we're going to commit in advance with stakeholders to take steps that we wouldn't otherwise take. And I want to give 3 examples, some which demonstrated the willingness to go forward, to move ahead and to take really courageous steps. And I think in California we can demonstrate that we're that innovative, but the silos exist. One, the IMG project, which we did. We were very excited that that was a DSRIP project through UCLA and had some seed funding earlier, a very generous grant from Kaiser. We all know that 25% of all physicians in the U.S. are foreign-trained physicians. What we learned in the LA area is that thousands, I've heard different numbers, but approximately 4,000, 4 to 5,000 physicians in the LA area were trained in Spanish-speaking countries, but most of them were not able to practice in the United States and were working as orderlies. We found them as working at McDonald's. These were individuals who could really add so much to the primary care crisis that we're in. UCLA went out and did a wonderful study to determine what were the obstacles that were preventing these individuals who had received the training in their home countries. And by the way, not a brain drain, they were already here. So they were already in California. Why were they not being picked up? And we learned there were a number of reasons. There were language issues, lack of familiarity with complex medical systems, academic medical centers. We surveyed all of that. And so UCLA created a boot camp program for these physicians so that they would score well, do well, and most importantly, they'd commit to practicing in Spanish-speaking underserved primary care areas. Wildly successful program, and this is a success. UC partnered with the medical board to go ahead and change regulations so that these individuals who are in a weird category, in addition to taking a history, could also touch the patient, do the physical. So that was a great success of looking at silos and changing what we needed to change in order to move this group forward. Not so successful is that many of the residency programs aren't taking these individuals, even though they've committed in advance to working in an underserved Spanish-speaking area in primary care. But Northwestern is grabbing them. So why are we training them in California so they can go to Illinois? So we need to look at some of the concerns that some residency programs have about taking IMGs. A second area, again, that would involve rethinking and being willing to move forward. E-consults, and I know I've chatted with some of you, and obviously great work. Mitch and you and I chatted a little bit.
10,000 a month we're up to.
Which is fantastic, the work that's happening there. But Mitch, wouldn't it go better if there was some way to attribute the RVUs to the specialists? Or maybe not. You and I have had that conversation, but at least to bridge. You and I, but at least to bridge. At least to make it so that if there was a way to get specialists and to recognize the PCPs that are going to continue to manage those populations? Is there a way? Eventually, no, but at least till we get there, have that conversation. And third, and I know this is very controversial, and I just bring it up because if we're going to show CMS that we're courageous, it's not, it's in many ways. We need to talk about team-based care, absolutely. Everything we have to do is got to be going on team-based care going forward. And we have to tackle the role of individuals who are not licensed as physicians in being able to help. And so I'm talking, of course, about pharmacists and nurse practitioners and PAs, community workers, promotoras. We can look at what's happening in other states. It's wonderful that we're looking at what's happening in other states this morning, but we need to take a look at that and determine if we can provide more access in a way that is higher quality and culturally competent by re-examining the individuals that are offering that care. Thank you.
Great, thank you. In following up with that, we've talked a little bit about goals and vision for California for if there is going to be a DSRIP 2.0. As you see it from where you stand, what do you think the goal and vision should be?
Well, if it's me, I think timely, affordable access to high-quality, culturally competent care. Erica said it beautifully. Giving somebody a card is not tantamount to access.
Bill?
The only way I could improve on that is just to say all those things and say with puppies. I mean, come on. So, I completely agree.
Well,
I'll add puppies and unicorns.
Yeah, but I'll say, no, that's not good. I don't think that's a good goal at all. Not for DSRIP. How are you going to prove that you did that? I mean, that's what CMS is. I mean, the words are all the words we agree with, but how do you know that you've done that? What they're asking for the money, which is not an unreasonable thing, is where are we now on that goal, which, and where are you going to be? And that's why I would turn it around and say, no, the goal has to be things that we can show we've done that support that. That is not a goal, that is our underlying vision. That's what we want everybody to have, but we need measurable goals or we will not succeed with CMS.
You don't think we can measure, for example, access? We know that what you've done, the great work, Mitch, with e-consults, we've really shortened, for example.
Yes. But that's what I'm saying is that the goal has to measure it, and at the same time has to be exciting to CMS. And so if you start getting too much in the weeds, that our goal is that within 48 hours after this, somebody gets this, that we're back to the 200-page manual, which maybe supports it, but that the things that we should be aiming for in DSRIP are high-level things that we believe, to use another one of Neil's examples, right? We're in an epidemic of opiate deaths in this country, more than heroin. It's past auto accidents. Why wouldn't we have in this waiver a goal that we're going to cut that rate by 30%? It's entirely measurable. It's killing people. They're overwhelmingly Medicaid people, although not exclusively. That's the kind of goal that I feel would excite CMS.
and this really gets into the role of quality, of efficacy, of value. And certainly there's a lot of lessons to be learned about how you measure that, and then how do you even tie that to broader goals. I mean, we've talked about the role of plans and outcomes measurement, other pay-for-performance measures. From your perspective, Dr. Katz, what can we do and what are some of the things that we might build into a DSRIP 2.0 to measure value and efficacy and quality?
Well, for example, I mean, and again, I think these are all like pieces of it, right? You need the vision, which we have, and I think it's beautifully stated by Erica. I think then you need what are the broad goals, and then you need sort of how you measure them and can, for example, add process. So I'll give one example. I obviously believe very strongly that longitudinal primary care is one of the few things that consistently comes up for improving quality and lowering cost. Most hospitals, though don't have any way of knowing whether or not somebody has a primary care doctor. It doesn't show up on the computer screen, right? You can see, the levels of a variety of esoteric laboratory tests that have been done, but who is the primary care doctor? One could require that as part of hospital systems, that every hospital, at a minimum, the hospital can't give the person on the way in a primary care doctor. But the hospital could have on its record a field for whether or not there is a primary care doctor. They could have in their system was something that existed in San Francisco General Hospital, which we're working on in LA, we don't yet have, is a email system so that you can email the primary care doctor as soon as the person hits the emergency room, right? And then you can email the doctor or nurse practitioner when the person is discharged, so that those then become part of the check boxes, so that it all builds toward the goal of meaningful longitudinal care for everybody who's in a hospital.
And go ahead, Cindy.
I guess my concern with that is, to some extent, I think that payers in general, the CMS being a payer, tend to also say, well, excuse me, but why the heck aren't you already doing that? Why do I have to pay you to do something that is in fact so integral to a good experience of care? You describe yourself as patient-centered, everyone. Well, if you're patient-centered, then why am I having to pay you to do the things that are right? And again, I don't mean it but I'm just saying that that's why when looking at what are the goals we should design, those goals, I think, do need to relate, unfortunately, as much perhaps to large system change as it does to those more incremental changes that we know, really should have been done 20 years ago. The technology exists to do them now. And we should basically just have a checklist that, I don't mean the normal a punch list that says, hey, these are the things we should have gotten done. We'll take care of those things. But we're going to look at larger system goals that really, in fact, create, and I come back to this term, the word bridge plan. And I don't mean it as the way it's used in when we discussed it in Cover California. But again, we have a huge issue with people moving in and out of eligibility for programs, and their provider system should never change, period. It should never change. And so to me, that's a goal that, that if I'm looking at it from a system, boy, that has some real punch, that has some real impact, and everybody then needs to work around that. So I guess I would just throw that out there. We had to have a little controversy.
Right, you're more of a system person, where the focus is the change, that the patients will benefit by changing the system. I started just in the opposite direction. I say, what does the system need to look like in order to deliver what I want to deliver to the patient? But they're very, actually, I think, mutually compatible. You want to do both, really.
And then when you get to DSRIP, I mean, that's exactly what you end up with, is you have goals that, in fact, relate to what are some of the more incremental things we do that improve the direct experience for the patient, improve it, make it higher satisfaction. And then those do roll into larger changes. So they're not incompatible at all, but I do think that we must keep in mind that increasingly payers I'm hearing them say, why aren't you already doing these things? So.
And of course, this gets into the question of form versus function, and then variability among systems. And I know, one of the key things that our state's grappling with is the realignment, the role of counties integrating mental health and behavioral health within managed care systems. I know folks on the panel probably have some thoughts on that. Bill, would you like to start off with us?
I want to respond to this discussion. I mean, the reason why I agree with Terry's assessment is that we are up against the fence here in terms of how much leaner we can get in terms of providing a value proposition to CMS in California. And the only way we're going to lower our cost structure is to reform the delivery system to lower cost providers who are going to address the specific needs of this target population that doctors don't necessarily address. We need delivery systems that address social determinants of health that are integrated in with physician care and hospital care. And that's why I think what you're saying is so important. I really think that's where we should go to deliver the value that's going to attract CMS. Because if you look at the past 10 years of Medicare Advantage and what we're doing now with CalMedi Connect and 5-Star, the way CMS sets targets, Mitch, they're going to decide what specific programs, what specific areas they're going to want to build in to a 5-star metric system for reductions. They're going to tell us what they want, But if we create globally capitated systems with the right mix of providers that can deliver the value, those systems will innovate to meet those performance metrics very quickly. Systems need the flexibility to do that and the expertise, and that's what we don't have right now, and I think that's what you're getting at, and that's why I agree with you.
Well, I appreciate that. I had the good fortune of my husband taking a job in Minnesota during the run-up of healthcare reform, right at the time when UC gave all of us a furlough day, 1 day a week off. So I agreed to teach health policy at the University of Minnesota while I was managing health policy in California. I just lived on a plane a lot. But one of the things, it was great because you do learn from other states what was going on in Minnesota. And one of the things I learned, it was an all faculty meeting with the dean of the School of Public Health, and Senator Amy Klobuchar came in, and then my counterpart from the Mayo came in and said, we're all friends, it's all Minnesotans. Let me show you how we're going to take money from California. And we're going to withhold our votes for health care reform. Now, if anybody from Minnesota is watching, it was, I think that was tongue-in-cheek, and I don't really think they were going to do that. But you can imagine, because I work for both systems, they were using the data from Elliot Fisher's, the Dartmouth index to show just how inefficient we were. And one of the things that they showed in Minnesota is look at how we use so many different kinds of providers. And right at the time that I was teaching in Minnesota, there was a huge controversy about the fact that I think at that time 13% of all ED visits were dental in nature. And we all know that there's so few dentists that will take Medicaid. And so what the state of Minnesota was proposing was a mid-level dental provider that would be confined to the Medicaid population to work with really the population that the other dentists had no interest in working with, and would be working in the ED to deal with these predictable dental emergencies. The fight in Minnesota amongst the dental association was huge. It was a big fight, even though these were not patients that the others wanted. I believe it passed, and it would be interesting to track and to see what's happened with, and I believe now they're working outside of the ED, and it would be very interesting to see whether the percentage of dental emergencies has gone down. I bet it has. So we have to look at these things.
So we're going to go to Neil and then Erica.
You raised a good point, Lisa, about process versus what is the population health metrics. And I saw Steve Chaw, who's the medical director of Medicaid, and asked him as much as I could about what about a DSRIP 2.0. That's where he said, well, maybe there will be. He was talking system-wide. And I want to point out that here's how I crystallized what he meant, because we talked about this. In smoking cessation, I think it'd be great, as Kaiser does, that they ask smoking status on every visit. And I think it'd be great for those who are identified as smokers, they refer to, say, the Smokers Helpline. That would be great. But the population metric is, even if that's done very well, is did you lower the smoking prevalence? Because we know that's about health. And so I think Mitch said this first, which it needs to be about. That's why our version of the triple aim, our 3-link goals, is health first. It's improving population health, it's improving health. And so the process measure is good, but Steve Chaw himself said, maybe when I'm thinking about population measures, it should be about lowering the smoking prevalence. You figure out how to do it. So that stuck with me, and as I said, that was last month at a national meeting.
I think you raise a really interesting point, Lisa, and I want to describe a policy idea that we've been working with at CAPH and now with our county association partners, which is in the same way that the low-income health program was a tight marriage with the DSRIP in the 2010 waiver. We think there is a way in the 2015 waiver to leverage the county-based structure in California around social determinants of health. And that, gosh, when I came out to California 10 years ago, on Capitol Hill we had a saying, you've seen one Medicaid program, you've seen one Medicaid program, and here you have to learn 58 of them. and it is so true that all delivery systems are highly localized and have their own history, politics, personalities, but they all have the same challenge of, on some level, being overly siloed at this point. And there's a real opportunity to create county-based pilots that would create incentives for payment reform, whether that's pooling shared savings or creating even perhaps global budgets that connect physical behavioral health, social services, transportation, housing, all of those services that counties today provide in somewhat disconnected ways. And so working with CSAC and other county associations and in conversations with the department, we're thinking, is there a way to, in the 2015 waiver, propose what we call a whole person care pilot and model different local ways, just as Terry's working in a particular community, different ways of providing integrated care and creating payment restructures that then could complement with a 2.0 DSRIP for the public healthcare systems, which are so often integral to that county system and have already been piloting ways on physical behavioral health and other issues. So we have some lessons learned to find that way that those two puzzle pieces fit together.
And that would certainly be a very compelling story to really look at the person holistically, to look across silos and across systems. At this point, we're going to open it up broader for questions from the audience. But I know there might be some folks who, because of time constraints, have to leave. I just want to remind folks that there are evaluations in your packets, so don't forget to fill those out and drop them off in the back with our folks. If you are on your way out, right now I'm going to turn it over to questions, and let's see, who do we have first who would like to ask a question? Anthony Wright. Let's start with Anthony. It's always great to get a consumer's perspective.
Thank you, Lisa. So I guess I wanted to tie the two panels together. I heard, we had great input from folks from other states, and so I would really be curious for the panel of folks about what you thought from the experience in other states was useful, both in terms of what we learned from what CMS is thinking, but also about what they were able to do. But also, so what were you inspired or interested in about what they were doing, but also what perhaps is really different in California, and so that we have to either adapt or change. What is, I think there was a reference to the that Medicaid is just differently funded and at a different level in California than some of these other states. I think that was, Bill mentioned that, but maybe it's the structure of the market, et cetera. So what are the things that are different that we would just have to adapt or think differently about?
I've got a couple of things that I've seen. Number one, when you are working on a regional basis, it means that you're picking your partners. And the process of picking partners means that you, in general, are going to be choosing those partners who are most readily capable of meeting your metrics as quickly as possible. You've got short timelines. Well, I think we have to be aware of how that potentially creates haves and have-nots. That, again, many of our more disadvantaged providers out in the communities may, in fact, just as an example, not have a sophisticated HIT capabilities for data reporting, for EMRs, to the extent that those are essential components of the selection process to participate. You must be aware as a state that you are in fact creating to some extent a greater gulf between have and have not in that. I think that's an important observation. Well, you can decide if it's important, but it is an observation that, that I really have seen in the selection process. The second thing is just the issue of competition. And the notion that at the top of all of our systems, we believe in competition. We believe that the private system and competition is really important. As you start looking at creating regional entities, and those start encroaching on the perception of whether there's good competition in an area or not, so that, again, traditionally health plans operate by pitting one provider against another. When all of a sudden those providers have joined up, that there are, again, legitimate issues, but also real perceived issues around anti-competitive behavior.
As we've talked about before, the previous DSRIPs have been about the public systems. If you were CMS, it's certainly sensible, we'll just choose Los Angeles, to say that what you most care about, if you're CMS, is the outcomes of Medicaid recipients and your overall costs. I mean, if I were at CMS, that's what I would say. That's my mission. High quality, lower the cost. So if you follow that line, then you'd say then a model like New York, where they've done that, makes sense. Where everybody is struggling, and Nirav and others alluded to it, is that the typical mechanisms for waiver or intergovernmental transfers and certified public expenditures. Those things are only generated by public entities. So if you're going to create an incentive program that's going to include your entire region, one of two things happens. You have to, if you can grow the pot, then everybody can benefit. If you can keep the pot only the same, then you're going to give the public entities less dollars. Public entities are sensitive about getting less dollars for two reasons. One is because they're reliant on it. So just again, to give people a sense of how these issues play out locally. In Los Angeles, the health reform in Medicaid has resulted in our having significantly more revenue than we used to have, because about half of our people who used to be uninsured got Medicaid. So we have a new source of revenue. If you march forward to the time when the dish payment cuts in half, if there is no waiver in place, then I will have less money than I had before the Medicaid expansion. So I'll have greater responsibilities and less money, which is another way of saying the same thing, is that the amount that I get from the Medicaid expansion is less than half the dish plus the waiver. Everybody still with me? Right. So I need the waiver in order to be able to continue to provide the service, because I'm already assuming the loss of half the dish. They can put it off, but there doesn't seem to be any inclination to take it away, and putting it off just makes the precipice more steep. So I think the question that everybody is puzzling about is, so if you support, on theory, the goal that CMS and us should care about the health of everybody in our county, and should therefore create an incentive on population goals that reward everybody, but the only money exists that can be used in this case exists on the public side. And because California has traditionally had a fairly narrow payment, the matchable money is relatively scarce, right? And all the state programs, Nirav talked about making a state program matchable, or maybe it was from Texas. Well, that's already been done here. So there may not be enough funds to make the idea work. And I think that's still what people are studying. Because if you can create enough funds to make it work, then it would seem like everybody would win. If you can't, then it all gets more difficult.
So if I can just add into Anthony's question, my takeaway from New York's recent experience is the focus by CMS on reduction of avoidable hospital admissions and readmissions. And I mean, we already have a high level of efficiency in California in Medicare Advantage. The national average in Medicare for bed days is like 1,700 per thousand. And high-performing Medicare Advantage groups are delivering bed days in the 600 bed days per thousand range in California, top third of delivery system. So, you know, one way to look at that is to dangle that metric in front of CMS and say, yeah, we have an infrastructure to do this. We can deliver that value and that cost savings to you. However, it has to be done in a new way in which hospitals don't close because of the heads and beds issue. And I think you go right back to globally capped delivery systems organized at the community level, like Erica was talking about, where everybody has a share in the revenue and they have to innovate to figure out how to devise it.
And this really does go back into this notion of the role of managed care, especially as we move all of Medicaid now in California is in managed care. New York certainly is different because New York, most of the providers are paid fee-for-service. And so by moving them into managed care, there's an opportunity through DSRIP to have the conversation around realignment of incentives and payments. I would love to hear the panel's thoughts on this whole issue of realignment, incentives, and the future role of plans.
Can I start on this one, guys? Okay, so
Have at it, Bill.
there's a lot of ways to do capitation. And what concerns me most is that dealing with this newly covered population and its healthcare needs, you still end up, just by capping a system, that doesn't get you where you need to be. A capitated system is not necessarily an outcome-driven payment model unless it's engineered very correctly. And one of the things that CMS has developed over the past few years in MA, for example, is risk scoring individual patients. And I really think that if you're going to develop a globally capitated system, you really have to get down to risk scoring these individual patients, and payment has to flow based on their individual level of acuity. And then on the back end, you hold the providers accountable to improve their health status over time based on specific metrics that are agreed with between providers and CMS, which is, I think, what Mitch was getting at. I really do. Targeting the high needs areas, the high cost areas. So I think we could gain a lot in California by pioneering that level of risk scoring now, in advance of CMS rolling out 5-star across the entire spectrum, beyond MA, into Medicaid, into commercial and the exchanges, which is where they're going to go.
Other reactions, thoughts from the panel?
I just want to get back to Anthony's, just New York. Learned so much from all of the panelists, but would love to have that data capability that they have in New York. That would be huge. I think it would help get to that sort of risk scoring. There's so much we could learn. But what also struck me was the willingness of the state to spend some of their general fund money. Yeah, I know that.
Toby's out of the room.
No, Toby's out of the room.
No, he isn't.
No, he's
He's right
not.
there.
There you are. I mean, there's a conversation about how bold are we willing to go, and especially if we have data. If we have data to demonstrate that we chose well, and these are initiatives that and the evidence exists to demonstrate a strong ROI.
Right. Any other questions from the audience? I thought I saw one in, yes.
So this is a question about the integration of federal waiver initiatives. As you may know, California is developing the drug Medicaid expansion waiver, and I think the opportunities there are really outstanding for having a substance abuse Medicaid treatment system in California that can really make a difference. It seems to me that the proper implementation of such a treatment model would really help the cost savings and outcomes across all of the systems represented here. And so I wondered if there was any thought or opportunity about supporting the actual implementation of that benefit as a part of the outcomes that we're trying to create in a DSRIP model.
I think this actually goes back to a broader question too of not only for the drug Medicaid program, but as I mentioned too earlier, the integration of mental health into primary care. What are the infrastructural supports, the programmatic supports that need to be built out? So I think it's really a design issue. And as part of that, and folks on the panel should please feel free to jump in, but the design really does follow the vision, and the vision needs to be established first, as I'm hearing some of the panelists say.
Yeah, I mean, I think that it's a key question, Marv. It's one that we need to think about how each component and element of a waiver proposal, not just DSRIP, this whole person care idea. There's another proposal to acknowledge the end of the era of safety net subsidies and evolve Medicaid DSH and safety net care pool financing into some sort of value-based payment. That too, all of that needs to be complementary to one another. It's a really important and astute observation that you're making, and I think it does lead to questions about, therefore, how to design it. And I would say it's not just about how the waiver components fit together, including the SUDS waiver, but also then how does the waiver fit into other statewide initiatives that are already on track. We had been wondering about CalSim, but even that notwithstanding, what about the coordinated care initiative and other statewide initiatives either already underway or already planned? Sort of the way I always say it is, what are all the puzzle pieces, and then how do they fit together to form what picture? You know, what is that vision? But I think you're exactly right that they have to fit together. And in some respects, because at the end of the day, we come back to the same issue of social determinants of health and patient-centeredness in the broadest sense of the term. So how are all of these fitting together, but also how are they complementary? In ways that CMS won't just say, well, that's duplicative, that's double dipping, but that really makes sense.
Yes, Neil.
I am in total agreement with how Erica outlined, and I would say besides, as you said, it goes beyond the waiver. Between Covered California, we know patients will be moving back and forth. And beyond that, what about, as Bill said, what's going on, what has IHA done, what's going on in the private sector and the private purchasers, and alignment. So I think we're all in agreement that as part of the behavioral health integration, the substance use portion of behavioral health, and the social dimensions of health, but it goes beyond DSRIP, it goes beyond waiver, and the department administration, and really I think all my colleagues on the panel are thinking what's going on in the private sector, and certainly with Covered California because of the movement between the two systems.
Yes, Chris.
Chris? Maybe you could so much noise.
So this is a question. I'll start with Mitch, and maybe others want to add from their perspective. But I know you haven't been with LA for a decade, but I wonder if you
It just feels that way.
That's right, maybe in dog years. I wonder if you could reflect back on, and maybe you think about it from the San Francisco hat, but I'm interested in both the sort of looking backward and looking forward. So looking backward would be, we're talking about in some ways, we've had an emphasis on population health population outcomes, and that's a good place to be. I'm also interested in the system transformation piece that gets us there. So how would you characterize LA, or if it's easier for you, San Francisco, what would be sort of the key things that you would say, these are the 3 key ways we are different now than we were 10 years ago, and in 10 years, here's how I hope to say we're different. Is it that we have behavioral health fully baked in? Is it that our workforce looks completely different? It's much more oriented towards, just what are those sort of big picture things? Not EHR can do this, or we have, so.
Well, big picture, the LA system 4 years ago when I got there was completely focused on emergency care. And if you could get anybody on the telephone, they would tell you if you were sick, go to the emergency room, right? Despite the fact that for 20 years there's been a movement to not go to the emergency room. In LA, they actually said, go to the emergency room, right? So, the movement for LA is to turn a system that is focused on hospitals and emergency departments into a system that is focused on primary care. And I agree very much with the other comments about, team care and trying to use alternatives to physicians. And so that's what a large part of our work has been. Mm-hmm. I think the work that I'm most interested in to continue is to establish much stronger expected practices throughout our system, which is how we evaluate in a scarce resource system, what are the right next steps. So to further drive down things like ionizing radiation and unnecessary drugs, unnecessary antibiotics, which are much more rife. I mean, one of the lessons to me of LA and to some extent other public systems is people always think that the overuse is driven by just fee-for-service or even just liability concerns. And it's amazing how much is inbred in physician training, right? To always give 3 antibiotics, to always do the next scan, right? A fair amount of the work is that physicians who have been at the head of the healthcare system for healthcare delivery, tend to be, smart, type A people who don't like uncertainty. And a lot of the modern medical system is explained by that, They want to find out what's wrong with you. Whether it helps you to know isn't really necessarily part of the thing, and it's part of sociology, so it matters to think. I think if you go even further, and I've tried to allude to it, what I believe is that especially very low-income people desperately need more connections in life. They need more connections to healthy friends and family, to useful work, to the medical system. And it may not be a doctor, and it may not be a visit. The people are hungering for connection. And that part of the challenge of going forward is how to deliver that connection. Because often part of the critique, even when it's a visit, is doctors, and to the extent that nurse practitioners and other mid-levels learn from the medical model, we have our own agenda, which is often completely different than what it is the patient is trying to get out of it. We have our checklist. This means this test, this means this drug. And the work of the next several years is to try to better align what it is people need to feel healed.
Mm-hmm. Absolutely.
This actually brings us to a question we really haven't talked about yet, which is, what expectations should we have of providers across systems to coordinate and collaborate, and how can DSRIP drive that? Terry, would you like to start?
Well, 2 of the 5 UCs, when I was asked to bring the 5 UC medical centers into this new world of DSRIP, and of course we hadn't heard about that, and Erica became my new best friend. 2 were not part of the formal public hospital system, and so kind of a lesson for private hospitals should they be brought in. I think we learned a lot. I mean, I would say that all of the UCs would say that this was a wonderful investment from CMS, and that the collaboration that occurred the sharing of best practices, creating the denominators for sepsis. What is sepsis? The learnings that occurred then created relationships. So now we just, at the same time I was developing the Innovation Center, we went on to fund 50 performance improvement projects. And I think that having DSRIP come first helped create that trust to where we could bring people who were otherwise competitors. They competed for NIH money, residents.
So you mean across all the public hospitals?
Well,
within
I was
DSRIP?
thinking about the 5 UCs because they really were competing for many things. So I do think that collaboration does occur, and there's nothing like financial incentives to help align that sort of collaboration.
Jill, Cindy, any other thoughts on who should be collaborating? What other providers should be part of the system?
I think, what I've observed from capitated organizations that are high performing is that they innovate very rapidly when they're given the freedom to do so through their payment structure, and they're held to outcome measures, which I think is critical. They have to be the right outcome measures. They have to be held to some process measures too, but I think the innovation comes with really weighting things toward outcome measures. And I think if we start to weight our outcomes more toward social determinants of health, you can evolve delivery systems to think and act and innovate in that level. And they haven't. They haven't. And I think what Mitch said, I totally agree with what Mitch said. You have to, over the next 10 years, I think the frontier here is developing delivery systems that do all of those things at the community level in a cooperative, collaborative, interdependent way.
So what type of partners would you hope to see in the next DSRIP waiver? Or who would be the stakeholders and participants that you would envision? And I'm opening this up to all of the
Okay,
participants.
there was one comment made about ACOs that I totally agreed with in the previous panel, because we've had a lot of experience with ACOs. We have 6 of the pioneers, we have a couple dozen of the MSSPs. And, the disappointment with ACOs so far is that they really haven't developed into those community level models. We're just not there yet. I just think that's where all the action has to go in the next 5 years. We have to broaden the number of stakeholders, the types. There's so many different types of stakeholders that have worked in the safety net forever. And those folks are completely siloed from the folks who run and create the ACOs. So I say throw them together in a pot, let them all swim together.
Cindy?
I would just add to that, this discussion really does, again, bring in this notion, as you said, of ACOs, because that is, in many ways, the organizing concept, certainly in Texas, I think, and in New York. And yet, if we really look at that ACO experience around the country, and even in California, we still end up seeing it isolated, developed in pockets, developed with a single payer, whereas the rest of the relationship with the other payers is still on a fee-for-service basis. And so, I guess my sense would be that if we're really saying that, number one, in California, we have had something that has been unique, and that is the delegated model. That has been something that overall has worked. It has in many ways been the central premise of Medicaid managed care, is to organize around these organized systems of care, capitated systems. And I guess I would say that is most akin to an ACO, and we should make sure that as we're looking at this concept of creating regionalism in our thinking as opposed to more centrally focused around the public hospitals, that we really make sure we're taking what's already worked in California before we just go and look to New York and say, wow, that's what they're doing, let's write that down. They were successful, let's write that down. It really requires some original thinking on our part to talk about how we take the best of what we've had, shore up the areas where it needs shoring up, and then really develop a very comprehensive strategy built on a good platform we already have in place.
So this really comes back to this question of regional planning and the role of regional planning. Terry, I know you're doing a lot of work with Sonoma County, I believe, and building upon that, where do you see as the role of regional planning, and how can it inform DSRIP projects?
Well, setting aside, and we have to talk about it, a very legitimate concern Mitch has articulated regarding the distribution of the scarce incentive dollars. So we have to hold on to that. So if we set aside that, county health departments know so much about the needs of their residents. They have the linkages, they form them. If they're not at the table, they need to be. In the particular county I'm working in, the county is acting as the backbone organization, and it's very effective. The FQHCs, they're delivering so much of the care. And so, again, we have to keep this other issue in mind. You've got other delivery systems. Not every county has a county hospital, so which of the privates are seeing most of the uninsured or the medical populations? And, and other organizations, there are other organizations, and I believe that the county health departments, if they haven't formed the linkages, they know which other organizations. Now, concerns, here's some of the concerns. In California, for very good reasons, we have the Brown Act and we have the Public Records Act. And in counties, I've worked in a couple different counties on that right care, the Million Hearts California version. And to the extent that you have a public agency that's acting as the convener, you may have a difficult time having the different hospitals want to share data, because that data may be discoverable. It's a small issue really in the overall scheme, but to the extent that the data has to be shared so that you can determine the trends for improvement, we're going to have to figure out different ways to be able to do that. And there's some obstacles, but they can be overcome.
Great. Neil, would you like the last word?
I just wanted to comment, I think it was a good question that you had, is what other partners ought to come to the table, and we really could even think broader, and this may not be limited to DSRIP and certainly not the 1115 waiver, but there was a 3-part series on NPR about what I call the San Antonio model, how they got law enforcement, social services, health services, mental health services all together. The jails were so overcrowded they were going to be taken over by the state. And it turned out that people were in jail who should have been in the mental health system or should have been in alcohol treatment. And they built a facility. By pooling resources, they were able to save something like $50 million in 3 years. So I would say the partners beyond the healthcare, the behavioral health, even the social system is into these other areas, because that's where super utilizers are. They're not only in the emergency department, but they're often potentially in legal trouble and get identified that way. So San Antonio's model is something that some of our partner hospitals are already looking at, Contra Costa for one. And so we're really, I think, all saying the same thing about trying to look beyond our immediate silos, to use the term that Terry did, but go even broader than perhaps we've had a chance to talk about this afternoon.
Great. So as we wrap up, I guess, what last parting words, advice would you give, sitting on where you're at right now, as to the state and to the broader stakeholder panel that is thinking about DSRIP and DSRIP implementation, like the future of DSRIP in California? And I guess I'll start on the other end of the table with Dr. Katz. Any last parting words?
Be bold. Let's really transform the system. It could be a lot better than it is, even though there are great people working throughout it.
My advice would be that the state has to put more money in. I think CMS is looking for more money from California, and I'm sorry to say that, but I think that's going to be essential.
I think the state has to get a lot more sophisticated about how it's pushing risk down to counties and providers.
Yes. Bill, could you say more a little bit about that and how it ties to DSRIP?
Well, I said before, I think we need to get down, we need to risk score individual patients, and payment needs to flow based on the acuity of the individual patient themselves.
And I agree with all of this, and in addition to the state perhaps providing a commitment for funding, other resources would be the state committing to the extent that they can remove obstacles with important programs that would make whatever the initiatives are that the group decides that this is important, we're going to roll this uphill, then to the extent that we need these obstacles removed, as we did with the medical board for the IMGs, find out how we can all go in the same direction.
Great, thank you.
I would just say keep the patient at the center, and no matter what the conversation, where it goes, always bring it back to what these patients need and how best to get them the care that they need, where and when they need it.
Last words, Neil.
I just want to say that the panel in the morning and afternoon and the material that was presented has been extremely valuable and will inform. We have a stakeholder meeting, as you alluded to, this Friday, so that will really help foster the discussion. I just think that the theme that I've heard over and over is we need to be thinking about patient-centeredness, improving health, population health, bring those two together and think about bringing together, getting out of the silos and linking together these needed resources to advance population health and to be patient-centered and deliver what members, patients, and families need. So I really appreciate all the input.
Great. With that, I want to thank everybody for coming today. I know we are going to now move over to closing remarks and evaluation. Richard, would you like to come join us?
Great. Thank you, Lisa. I'm Richard Thomason, Director of Healthcare and Coverage Program for Blue Shield of California Foundation. We've been really pleased to co-sponsor today's DSRIP Forum with the California Healthcare Foundation. So thank you all for coming, and thanks everybody for being on the panels. Just wanted to give a couple of last points, and actually one of the real themes that's coming out of today for me is just the real need for the state and all of us to come together to really think about what is our 2020 vision for this waiver. We've got the DSRIP, there's the various other work groups, and I don't think yet we have a really compelling idea, vision, path forward for how this all fits together. And since we very much heard today that CMS will be looking for that kind of compelling vision, I did want to give one last opportunity to our two visitors from other states. So maybe if Nirav wants to start with a microphone, just in terms of, so as you've listened to the discussion today, what would your advice be to us in terms of how we can pitch all this to CMS most effectively?
Sure. So first and foremost, I am one of you now. I live in LA, so I'm fully invested in our success. I have to say, California figured it out and did it once. We can do it again. We can reinvent it, and we have to just think broadly. We have to think of who our partners are. Perhaps Kaiser Permanente is a partner. I can't speak on behalf of that organization. But the reality is there is the brain power. The solutions are in this room. The solutions are in the communities with these points of light across the 58 counties. So I'm actually quite encouraged by the conversation today. You're asking the right questions, and now we just need to collectively answer them.
Thank you. Well, Tom?
Yeah, a couple of thoughts. Couple of thoughts, I guess, on how to sell to CMS. I agree. I think there were some excellent points today and a lot of questions. I keep going back to sort of what is solved in DSRIP and what is the state's vision overall above and around that. And so not everything can be solved at DSRIP. Sort of bringing all the partners and all the folks together that deal with the same populations makes a lot of sense. I think one of the challenges in designing DSRIP is you're trying to rationalize a program on top of an irrational system, at least of financing underneath it with IGTs and CPEs and so forth. So that makes it challenging to do everything you're trying to do within the DSRIP program. You talked about the goals, so what I think going bold and going high is the right way. You know, perhaps, and again, whether this is the DSRIP goal or the state of California's goal, perhaps something, you know, cut your uninsurance rate in half at the end of 5 years, or getting your medical spend down by X, you know, regular medical inflation. So what is the state doing around that, and how does DSRIP fit in with whatever else is going on, all the initiatives, including other parts of the Medicaid program? You know, somebody brought up as a goal the opiate. I think that's an excellent goal. 30% would certainly be an ambitious reduction. But certainly, as an example, that's not exclusively Medicaid. That problem's a middle-class problem now. So CMS might ask, well, what is Blue Cross doing about that? So you don't try to solve it just within DSRIP or Medicaid. What is the state doing about that? Because they've chosen that as one of the state goals, and this is why it's in DSRIP and what we're going to do to have Medicaid drive its part of that, for example.
Great, thank you. So if you really enjoyed today, we do have more work group meetings for all the different elements of the waiver going forward December and January. So there's more opportunities to engage around this question of what the DSRIP should look like, how it should relate to the other parts of the waiver. So I really encourage everyone to take a look at the state's website for the waiver work and follow it and attend meetings and give us your input. And I just want to call out two of the tensions that I really heard coming through today that will be important for us all to wrestle with as we develop this 2020 vision and figure out what this waiver proposal will be. One, this morning, Toby and Chris both mentioned this theme of transformation. Toby also talked about how one of the purposes of the original DSRIP was to provide stability to the safety net. Those two things are kind of inherently contradictory. So if you're stable, you may not be transforming. If you're transforming, that's going to feel unstable. So I think we all need to keep that tension in mind as we weigh the different proposals that will come forward. And then the other tension, I think, was really called out very nicely in Peter Harbage's paper of past DSRIPs and the existing DSRIP being hospital transformation versus regional transformation, and you heard a lot of discussion about that today. So from the point of view of Blue Shield of California Foundation, we have worked with many of you around these questions of safety net integration, of trying to break down silos across different parts of the safety net throughout California. And so certainly we think there's a lot of opportunity in both the hospital and regional transformation approaches, but I think as we look 5 and 10 years down the road, these questions of regional work, these questions of social determinants of health, these questions of how do we move this whole system in a more population health direction really are going to come to the fore. So I think those are the very simple and easy to answer questions for us all to grapple with in the coming months. So look forward to that conversation. So a few last housekeeping measures. All right, we're foundations. We love evaluations. Fill out your evaluations. They're in your packets. They're the goldenrod, a box for them, and pencils at the back table. Extra packets over there of the materials that were presented today. There's lunches left over if you've got people back in the office who may be hungry. And then finally, I just want to thank the whole team that put today's great forum together. Peter and Lisa and Ingrid from Harbage Consulting, Chris Perrone and his team at California Healthcare Foundation, and Director Toby Douglas and his staff from DHCS. So without them, this wouldn't have happened. So thank you all for coming, and we'll see you at meetings to come. Thanks.